Hi, everyone. Welcome to the Lymphoma Research Foundation's update on cutaneous T-cell lymphoma webinar. I'm Hope Avalone, and I'm the Senior Manager of Patient Education here at the Lymphoma Research Foundation. And during today's webinar, you'll hear from an expert speaker, and you'll have the opportunity to ask questions. You can ask those questions at any time in the Q&A box at the bottom of your screen, and we'll address as many as we can before the conclusion of the program. But as a reminder, this webinar is being recorded. At the end of the program, you'll be prompted to complete a program evaluation, and we do ask that you complete this evaluation as we love to incorporate your feedback into future programming. But for now, let's get started. Welcome everyone again, and thank you for joining us for today's webinar. We'd like to thank our sponsors of this webinar, Genentech, Mallinckrodt, and Merck. And before we begin with the program, I'd like to share some additional information about the Lymphoma Research Foundation. We're the nation's largest nonprofit organization that focuses specifically on lymphoma, and our mission is to eradicate lymphoma and to serve those touched by the disease. All of our work is led by our Scientific Advisory Board, which is a group of 45 leading lymphoma experts from around the country. And in addition to today's program, we have a variety of other programs and services available for you. So one example is our helpline, which serves to complement our patient education programs like this one. The helpline has master's level trained staff who provide individualized information on all types of lymphomas, as well as information on treatment options, clinical trial navigation, and connections to resources such as financial assistance. We also offer a peer support program called the Lymphoma Support Network. Through the Lymphoma Support Network, we can connect patients and caregivers with others who have been through similar experiences or for emotional support. And in addition, the foundation has free comprehensive disease guides and fact sheets, which can be ordered or downloaded on our website at lymphoma.org. We also offer a variety of other in-person and virtual educational programming so that you can continue learning about the latest updates throughout the year. And finally, we have an award-winning mobile app called Focus on Lymphoma, and the app provides helpful disease content as well as unique tools to help you better manage your lymphoma. The app is available free of charge in the Apple App Store and in Google Play. And I also wanted to briefly highlight our upcoming Mid-Atlantic Lymphoma Workshop in Washington, D.C. Lymphoma workshops are one-day educational programs that provide the latest information about lymphoma, current treatment options, and patient support issues. So the workshop will actually include a specific breakout on T-cell lymphoma, specifically highlighting CTCL as well. And it will be held on Saturday, June 15th. So not this weekend, but the next upcoming weekend. And you can view the agenda and register for this program at lymphoma.org/Mid-Atlantic Workshop. We have a wonderful program planned for you today, and I am honored to introduce our speaker, Dr. Michi Shinohara. Dr. Shinohara is the director of the Cutaneous Lymphoma Clinic at Fred Hutchinson Cancer Center. She's also the director of dermatopathology at the University of Washington. Thank you so much, Dr. Shinohara, for speaking at our program today, and I'll now turn the talk over to you.
Thank you, Hope. Share my screen. Okay.
You have to switch those two again.
Thank you. It was like, which one are you seeing? All right. Well, I'm excited to talk to you today.
I think you might have to
Thank you. Okay, switch again. I was like, no, it looks funny. Yes?
So I still see your notes for some reason.
Okay, let's try again.
Bye.
We got it right before, so I know it's possible. Let me do this.
This looks good.
All right, great. Fourth time's a charm. I'm excited to talk about cutaneous T-cell lymphomas with you today. And my disclosures are that I'm an investigator for several clinical trials. And then I received some research funding through Kyowa Kirin. And another disclosure is that I'm on the National Comprehensive Cancer Network panel for T-cell lymphomas, and I'll acknowledge that when we get there. The agenda, I want to give some general overview. And because I'm a dermatopathologist, I'm going to spend a little bit of time talking about why is it so hard to diagnose cutaneous T-cell lymphomas, and give you a little bit of background on some special techniques that are used that you may have had done. And then spend a little bit of time talking about some new therapies and some updates from the World Congress of Cutaneous Lymphoma, which happened just this past March. So I want to just start out with some terms. When I say primary cutaneous lymphoma, I mean only in the skin or skin first. So they could potentially involve other organs, but generally when people say primary cutaneous lymphomas, they mean they started in the skin. They are all classified as non-Hodgkin's lymphoma. And, most lymphomas are actually non-Hodgkin's lymphoma, except for Hodgkin's lymphoma. And they are totally distinct from systemic or internal lymphomas, meaning that these have their own staging systems, totally separate clinical trials for the most part. And I'm going to say CTCL a lot. When I say that, I'm usually meaning mycosis fungoides or Sézary syndrome. But technically, CTCL is a broader term that involves all these other types of cutaneous lymphoma, including anaplastic large cell lymphoma, lymphomatous papulosis, non-mycosis fungoides variants of CTCL. And in general, cutaneous lymphoma are rare diseases. The overall incidence is about 1 in 100,000. But cutaneous T-cell lymphomas are more common than B-cell lymphomas, and I'll tell you more about that in a second. But again, when I say CTCL, I generally am talking about mycosis fungoides and Sézary, since those two are one of the biggest chunks in the pie here. Why are cutaneous T-cell lymphomas so much more common than B-cell lymphomas? One of the main reasons is because the normal human skin contains really a lot of T cells. Actually, 1 million T cells per centimeter squared, or about a half an inch. That's twice the volume that's in the blood. So there's just a lot of potential fodder in the skin. Mycosis fungoides is the most common type of cutaneous T-cell lymphoma, and this is a historic drawing of mycosis fungoides. It's a terrible name. It means fungus, and we know it's not fungal, but we think some of the early examples of this where people had unchecked disease with sort of fungating tumors may have informed the name. But it's a lymphoma that originates, we believe, with what are called skin resident T cells. So T cells that primarily live in the skin. They have little address tags that keep them in the skin. And here's some clinical images of people with early mycosis fungoides showing kind of ill-defined or non-distinct pink patches. Very common to have them in the sun-protected sites. Here's somebody with some more papules coalescing into patches or plaques. And here's somebody with darker skin tone, because it can show up sometimes just like pigment change. With more advanced disease, people can get what are called plaques or even tumors, or erythroderma, which is defined as redness in the skin that encompasses more than 80% of the skin surface. Sézary syndrome is what's called the leukemic form of cutaneous T-cell lymphoma. And by leukemic, it means circulating in the blood. And that picture is a picture of a Sézary cell in the blood, an atypical T-cell in the blood. And clinically, Sézary syndrome is defined by the characteristic triad of erythroderma, redness from head to toe, those circulating abnormal T cells in the blood, and lymphadenopathy or swollen lymph nodes. And Sézary syndrome, we're now learning, is likely distinct from mycosis fungoides, although I'll acknowledge there's still a lot of debate about this. But we think it probably originates with a different type of T cell that instead of homing to the skin, it hones to the lymph nodes. They're called central memory T cells. So they're T cells that can go in and out of the skin, but they really belong in the lymph node and the blood. Here's some clinical pictures of people with Sézary syndrome with that erythroderma, that really widespread redness from head to toe. And I want to, like I said, mention a little bit about diagnosing cutaneous lymphoma and talk about why is it so difficult. We have lots of tools that we use to diagnose cutaneous lymphoma. It's never made just on one piece of information. We definitely have to have typical history. We have to have a good exam with typical findings, skin biopsy, often multiple, and then usually blood tests and maybe imaging depending on the stage of suspected CTCL. And I'm a dermatopathologist, meaning I spend a chunk of my time looking at skin pathology under the microscope. So I'm going to show you some pictures. These are images of what mycosis fungoides or Sézary syndrome would look like under the microscope. This is the top surface of the skin here. This is what's called the epidermis. And we see these collections of cells in the epidermis. Those are the atypical T cells of mycosis fungoides. And here's a closer up look of a collection or potria microabscess of atypical T cells in the epidermis. And Sézary syndrome and mycosis fungoides can look very similar under the microscope. And as I mentioned, and you might have experienced yourself or your family member, it is really hard to diagnose cutaneous lymphoma. On average, there's 2 to 4 years from the onset of disease to diagnosis. And in my experience, that's, pretty typical. The first biopsy, skin biopsy that someone has is only diagnostic about a quarter of the time, and that's based on data. This is a study where people looked at how many skin biopsies did it take before a patient got a sort of slam dunk diagnosis of cutaneous T-cell lymphoma. And you can see that some people had up to a dozen biopsies before they got to that 100% chance. And so, that one biopsy only diagnostic about a quarter of the time, but when you get up to 4, 5, 6, the chances get better. And so it's very typical that people will need that many biopsies, especially for early disease. And here's a schematic about why that might be. In this image, the pink is the epidermis, the top surface of the skin. And the little red guys are the atypical T cells, the mycosis fungoides cells, for example. And the green guys, or the green circles, are healthy, reactive T cells that are actually there doing antiviral, anti-cancer. They're kind of part of our healthy, normal immune system. And in early mycosis fungoides, it's very common to have just a little bit of a small population of the atypical T cells and a lot of reactive T cells. When we take a biopsy, we're mostly seeing healthy, normal immune system. It's very hard to pick out those atypical cells. If disease gets more advanced and you get into thicker plaques or even tumors, now the volume of the tumor cells, the red guys, really increases and it's much easier to pick it up. If you get very far on the other extreme to erythroderma or Sézary syndrome, now the volume of tumor cells in the skin is again low because those cells are really circulating in and out of the skin. And again, it can be hard to diagnose by skin biopsy. So that's just a schematic, but we've got lots of other tools to help us with diagnosis. And I'm going to walk through a couple that people often ask me about in their reports. One is immunohistochemical stains or markers, and then another are some molecular DNA-based studies. So when people say markers, what they mean are these little address tags that are present on all the cells in our body, not just T cells. Every cell in our body has molecules or antigens on their surface that act like name tags or address labels. It helps other cells to identify them, and it tells them where they're supposed to go in the body. And that's especially true for immune cells because they can go from different compartments, skin, blood, lymph nodes. And the particular combination of these molecules, these address tags, is what gives a cell its signature. A T cell generally has several molecules, including CD2, CD3, CD4, and those molecules help define what type of T cell it is. In this case, the CD4 identifies it as a CD4 positive or helper T cells. So we look, when somebody gets a biopsy, we look for particular combinations of these markers by putting antibodies against these markers on slices of tissue. And here's an example of what that would look like. On the left, that's what we see when you just take a regular biopsy, what's called the hematoxylin and eosin stain. It's just a regular stain that everybody looks at routinely day to day. And on the right, we've actually done an antibody against CD30 to say, is that CD30 address tag on some of these cells? And the brown stain is positive. And so in this case, this person does have some CD30 in their tissue. So when people say markers, that's what they mean. They put antibodies against those on the skin sample. Some markers are totally normal to have, and some are not. Then molecular studies are another sort of class of testing that's often done to diagnose lymphoma in general. And the ones I'm going to talk about are gene rearrangement or clonality studies and next generation sequencing. You might have also heard about flow cytometry. That's often included in molecular studies. We won't talk about that today. I'm happy to answer questions about it if I can. And what gene rearrangement or clonality studies are looking for is whether the T cells are identical clones or what I call, twins, or are they cousins? So normal day-to-day, our immune system is just hanging out, waiting to respond to things, waiting to respond to infections, cancer, and they're already pre-programmed to design to attack different things, staph, candida. In the setting of lymphoma, though, some of this population will start to divide and dominate. So normal or polyclonal, we have all these T cells which are different. They're, this blue one might be designated towards candida, the white one towards staph. They're all waiting to do their job. But in the setting of lymphoma, some of those cells are now dominating the population. And so we get a situation called monoclonality, and that would actually be a positive clonality study when it's monoclonal. We actually get a report that looks like this. There's a spike that tells you there's a positive clone, and this would support there being a lymphoma. Next generation sequencing is a variant it can be a variant of clonality testing. The other name for it is high throughput sequencing. And this is kind of new technology that's being used in a lot of different settings in medicine. But this next generation sequencing is a much faster, more efficient way of getting DNA or gene sequences. This is how the Human Genome Project, for example, was evaluated. And there's kind of two ways you can use next generation sequencing. In this context of what we were just talking about with clonality, you can use it for that as a different method to look at clonality. You could look at it to see, are there characteristic mutations that might suggest a particular type of lymphoma over another? So those are ways that you could use next generation sequencing for diagnosis. And then there's also growing evidence that it may be helpful for management and also prediction of clinical behavior. For the case of cutaneous T-cell lymphoma, we know that having a higher volume of clones, what's called a tumor clone frequency, could be a predictor of clinical behavior. So that's a data point you could get from next generation sequencing. And also there sometimes are particular mutations that you can find with next generation sequencing that can be associated with a particular treatment. For example, you could find what are called a JAK-STAT mutation, which might indicate that somebody's lymphoma might respond to a JAK inhibitor medication. So we call those actionable mutations. If we look and see what type of mutations does this cancer have, all cancers have mutations. And when we do that, that's called precision medicine, because now we're looking for a very specific mutation, which might indicate a treatment that only that lymphoma or that lymphoma specifically may respond to. When I talk about high throughput sequencing for clonality studies, I showed you this picture of what traditional clonality studies might look like with a positive test. You might have all these red guys that are proliferating and making a dominant clone. In the setting of next generations or high throughput sequencing, though, we can actually find out that these red guys may actually not be identical. They may just be very similar looking. And so we could get positive tests that are actually negative. So it actually has higher specificity than regular clonality studies when we're using it for this purpose. So it's kind of the next step that people are taking. High throughput sequencing isn't available at every institution, but I think that is where things are going to go. Okay, we're going to pivot a little bit towards treatment. And reminder that I am on the panel for the primary cutaneous lymphoma, T-cell lymphoma panel from the NCCN. So I'm going to show you some of their guidelines. The NCCN is this consortium of groups around the country that really look at evidence for different treatments. And they don't recommend one over another unless evidence supports that. And this is a little bit outdated. We have newer version of this now, but this is an example of what the guidelines for mycosis fungoides and Sézary syndrome look like. Category A are, more recommended. This is for more advanced disease, as an example. So, there's lots of options. They're alphabetical. And so that can be a challenge if somebody doesn't know these medications, which is why, even though these guidelines are really helpful, if somebody who doesn't have a lot of experience treating patients with cutaneous lymphoma is really only relying on the guidelines, like they might just start at the top and, they're alphabetical and not necessarily in order of what may be the right thing for a particular patient, and still helpful to have. Some principles that we use, that most experts use in treating cutaneous lymphomas are what I like to call fitting the punishment to the crime. This was my mentor, John Olerud, at University of Washington, used to say this to patients too. And what he meant by that is, like, if somebody has very early disease, we're not going to hit it with a sledgehammer. It's a misdemeanor. We're not going to, put them into prison for life. If somebody has very advanced disease, now let's step it up and use treatments that may be necessary for that. The other principle is that, in general, right now, our goal for treating patients with cutaneous lymphoma is control of their disease, not cure. We have essentially no cures, with the possible exception of stem cell transplant. We really want to manage itch and superinfection for patients when they're present. Clinical trial whenever possible, because we need more treatments, especially for advanced disease. And our highest priority really should be improving quality of life for patients. This is an overview of a current approach to treatment of mycosis fungoides and Sézary syndrome. This was inspired by another one of my mentors, Jun Kim. And really, it's just talking about with early disease or stage 1A, you're going to mostly be sticking to skin-directed therapy, possibly considering a clinical trial if one's available. With stage 1B or more generalized disease, you may be moving into oral agents, maybe infusion agents. And with more advanced disease, tumors, erythroderma, you're almost certainly going to be using some type of systemic agent, either an infusion, maybe even talking about transplant. And clinical trial really is appropriate across the board if it's available. And the other concept here is that skin-directed therapy or management of skin symptoms really should occur across the board too. So just because somebody has advanced disease doesn't mean we stop managing their skin, because that oftentimes impacts quality of life. Another comment about treatments: the average response rate right now for many treatments, especially for advanced CTCL, is about 30%, which, you might hear that and think that's pretty low. That's what I think when I hear that. So it's not true across the board. There are some treatments that are more effective, particularly for certain subtypes. But if you just look at all the clinical trials, on average, the total response rate is about 30%. So why aren't we better in this day and age at treating cutaneous T-cell lymphoma? What is going on with that? And I want to talk a little bit about what we know about what we call the molecular landscape, or really the genetic background of CTCL, because I think it helps understand a little bit why our treatments are not more effective. And really the principle that I think is important to understand is that mycosis fungoides Sézary syndrome are very complex mutationally, meaning that if you compare two patients with CTCL, the mutations that they have that led to their lymphoma are often not the same. And even within one patient, you can have different mutations across your disease. So we call that mutationally complex. And what that means is that it's very hard to find a single targeted treatment that's going to work for everybody, because everybody's disease is a little bit different. And individual patients can carry multiple what we call subclones, so their disease can be different in different areas of the body. This is a study from a few years ago showing that concept of mutational complexity. SV is a somatic variant. Those are basically little genetic differences. And here we're looking at patches, plaques, and tumors, so advancing disease as you move to the right, and number of somatic variants is really a surrogate for complexity. So having more somatic variants means you have more mutations, basically. So as you go from thin patches to tumors, the number of mutations goes up. There's full fourfold increase between patches and tumors. And this is that concept of individual topographic heterogeneity. Meaning that for a single patient, you could have one area of the body which shows one, what we call morphology, so small bumps, that shows one set of mutations. Another area could show a different morphology, and these are all the same patient, by the way, and a different set of mutations. And then yet another area, another morphology, another set of mutations. Makes it very hard to pick one treatment to treat the whole patient. So our future approach to the treatment of cutaneous T-cell lymphoma, we all recognize really needs to rely more heavily on individualized therapy, or what we call personalized or precision medicine. I think this is the area where we're still behind. We have not, because of that difference between patients, that heterogeneity, we haven't yet been able to identify all the different targets that may be effective. And so what current research is really, of course, we're looking for what are those mutation patterns, but in terms of current trials, a lot of them are really focusing on what we call targeted therapy, and then harnessing the immune system, because the concept of harnessing the immune system, we'll get more into it, but it's really like, it doesn't matter as much what somebody's individual mutations are if you're able to turn the immune system on and help it do its job. So an example just of a targeted therapy, when I say that, people often mean different things when they say that, but brentuximab vedotin is an example that I like of a targeted therapy. Brentuximab vedotin is an antibody drug that's what's called a conjugate. So it's an antibody against the CD30 molecule, but it's conjugated or attached to a toxin called monomoral auristatin E, which is basically a poison. So in this diagram, the little upside down Y is the antibody and the red guy is the toxin. And what happens is that antibody binds to a cell, a lymphoma cell that has CD30 on the surface. That's the green guy. And once the antibody and the drug bind, they get taken in, and then the antibody drug is cleaved and releases the toxin, which then goes in and interferes with DNA of the tumor cell, causes cell death. So it's like a stealth bomb getting sucked into cells that express the target, which is CD30. And so that's an example of what I consider targeted therapy, instead of being kind of like old school chemo where you're coming in just like trying to, firebomb everything. This is more stealth, coming in just where it's needed. Brentuximab vedotin is approved for non-Hodgkin lymphoma. There was a phase 2 trial that included patients with mycosis fungoides and Sézary syndrome. And I mentioned the 30% response rate. It was better in patients in this group. And, up to 70%, especially if patients had a lot of CD30 expression at the time of their biopsy, though it can work even with low CD30. And then another example of a targeted therapy, which we're using a lot right now, is mogamulizumab. Mogamulizumab is an antibody drug against CCR4. CCR4 is it's called a chemokine receptor that is expressed in CTCL, especially in Sézary syndrome cells. But CCR4 is also expressed on some of the immune cells in what we call the tumor microenvironment, or the environment around the cancer cell. And so in this diagram, the CCR4 is the red squiggle. And the T regulatory cell is part of the normal healthy immune system that also has the CCR4 antibody. And, sorry, CCR4 antigen or target. And what mogamulizumab does, it's again that upside down antibody, because it's the antibody drug, it binds to that CCR4 on both tumor cells, but also on T regulatory cells. And as part of that, it turns some of these into anti-cancer T cells. So it can attack this tumor directly, but we think it may also have this other sideways effect of activating the immune system. It can cause some infusion reactions. All antibody drugs can. And then in particular, it can cause this thing that we call MOGA-associated rash, or MAR. And here's an example of a patient who is pre-treatment with mogamulizumab. So she has not yet had it. This is her baseline disease. And then here she is after having clearance of her blood with mogamulizumab, but now having a new rash from the drug. And we think this happens because of that activation of the immune system around it. And there's ways we can manage it. It may portend a better prognosis to the drug, but it can have this unintended consequence. Then the last area I'm going to talk about is an area I'm particularly excited about, because I think this is where a lot of cancer treatment is going across the board, which is really trying to maximize the anti-cancer immune response. So what's happening in, all cancers is that our immune system, whose role is not only to fight infection, but to keep cancer at bay, is tolerating the cancer. Either the cancer is growing so fast that it's outgrowing our immune system's ability to keep it in check, or it's growing so slowly that it's sort of evading our normal responses. And so what a lot of cancer treatments are geared towards is like turning that immune system back on, like, hey, there's something wrong here. You need to get back to work. In this image, the center cell is a tumor cell. It could be anything. We'll say it's a T cell. But around every tumor cell is what's called the tumor microenvironment. There's other immune cells around it because they just choose to do something or not. So in the case of mycosis fungoides, our tumor microenvironment is our other cells in the skin, including anti-cancer T cells and something called macrophages. In the best case scenario, what would happen if there were a tumor cell there that our immune system recognized normally is that anti-cancer T cell would get activated, and it would shoot out all these signals to the immune system around it to say, like, hey, get to work. There's something funny happening here. And then those tumor cells would get gobbled up by macrophages. So it would look kind of like this. The anti-cancer T cell would be like shooting out all these messages to the neighboring immune system. And the macrophages would turn into Pac-Mans gobbling up tumor cells. And even better, if they would then gobble them up, process them, and send out messages themselves saying, hey, there's something going on here. Everybody be alert. That would be the ideal anti-cancer immune response. But in reality, what happens is that tumor cells have ways of evading our immune system. That's how they survive. And so they have messages to tell anti-cancer T cells, nothing to see here, everything's fine. Similar messaging can happen to macrophages. And so a lot of cancer treatments right now are trying to address this signal, which we call the off signal. An example of that are what you might have heard are checkpoint inhibitors. This is like what Jimmy Carter got for his melanoma. They're signals that are antibodies that address this off signal that tumor cells are telling our immune system. And they say, no, no, actually, wake up, time out. There's something to do here. Towards that messaging, I'm going to give you a couple studies, a couple updates from the World Congress of Cutaneous Lymphoma, which happened just this past spring. This meeting is infrequent, but excellent. And I mentioned this anti-cancer immune response. There are lots of messages, between tumor cells and the what we call tumor microenvironment, including those anti-cancer T cells. One of the address tags on tumor cells is this molecule called KIR3DL2. And that turns out to be widely expressed in cutaneous lymphomas, especially in circulating tumor cells, so like patients with Sézary syndrome. This KIR3DL2 is a molecule that its binding partner is a natural killer receptor. And natural killer receptors, when they are turned on, they activate that macrophage system. So they tell the immune system around them, get to work. So there was already a phase one trials are safety trials. So they're in the setting of cancer, they're often used, they're often performed on patients with disease, but phase one trials may be performed on healthy volunteers too. Phase one trials generally are not enough to get FDA approval for a drug. In the US, you generally have to do a phase 2 or phase 3 trial to prove safety in a larger group and also efficacy. So that phase 2 trial for this drug against the KIR3DL2 antibody drug was recently completed, and there was a preliminary report about that. This, because it was done in patients who had to have circulating cells, because it looks like it's going to be more effective for that. All the patients in the trial had previously received mogamulizumab. So far, the results look pretty promising. The overall response rates are around 45 to 50%, with a very rapid response. Median time to response in the blood looked like about a month, which is pretty fast. And what seems like the really exciting thing about this antibody drug is that the safety profile is really good. So really very few side effects. Of course, trials are small. I think the number of patients in this so far is like in the mid 50s. It often isn't until patients, hundreds, thousands of patients are treated that some of the more rare side effects come out. But here's a couple examples of patients who were treated with this drug, lacutamab. This is the anti-KIR3 drug. The patient on the left, I think the pictures are the best view. The lower left image is a PET scan of a patient, and all the black is where there's significant uptake. Normal to have uptake in the heart and the bladder and the kidneys. But all these areas in the armpits and the groin, those are abnormal areas of uptake. That patient also had increase in Sézary cells at baseline. They had MSWAT, which was almost 100. 100 is maximum. That means they were red all over. And then they had lymph node involvement. By week 45, so almost a year of treatment, they had a global complete response, B0, so less than 100 Sézary cells, skin clear, lymph node clear. Similar with the patient on the right. So this third image, lots of uptake in the armpits and groin, higher Sézary level now of 5,000, again, down almost undetectable, skin clear, lymph node clear. So those are, of course, really good examples, and not every patient is going to have that type of response. But the exciting thing is the patient on the right, they had their complete response by week 13. So that's, a little over 3 months. That would be really exciting. So this drug is not yet FDA approved. Of course, that process takes a long time, but one report from there. Another report that I thought was interesting was the study looking at maintenance treatment for cutaneous T-cell lymphoma. So the concept here is that in cancer treatment in general, lymphoma treatment, we don't tend to do maintenance for most patients. And in fact, what's very common is that if patients have a partial or a good response, it's encouraged to take a treatment break in many types of cancer. And the thinking behind that is if you keep pressuring the cancer with treatment, that's not curing it, you may be promoting additional mutations in the cancer, which then lead to resistance later. And so, kind of a general principle for many cancers is treat it hard, take a break, treat it hard, take a break. But in the case of cutaneous lymphoma, that really clinically day to day hasn't borne out. People's experiences, hey, when we take that break, patient's disease comes back. And sometimes it's, worse than it was before. So are we really doing a disservice by approaching it that way? And so this study was looking at, is it helpful to do a maintenance treatment after a treatment that's designed to hit it hard? Can you then extend the time until another treatment is needed? And so on the left here is somebody who's pre-treatment. They have what we would call a disease reducing treatment, or they would have a treatment like a systemic treatment, for example, that caused a significant improvement in their disease burden, less patches. Now we're looking at, can we increase the time to next treatment until another treatment is needed? And so this study was looking at a particular drug. This is a drug that I believe is not currently approved in the U.S., but it's approved in the UK and Japan. It's a relative of vorinostat and romidepsin, an HDAC inhibitor. They looked at that drug versus placebo. All patients had advanced mycosis fungoides or surgery, and they looked at either treating with nothing versus giving them this reminostat, this HDAC treatment, as maintenance after they finished their systemic therapy. Like they got romidepsin, they got pralatrexate, they got total skin electron beam, and then they got a course of this reminostat as maintenance. And then they looked how long on average until people needed another treatment. And what they found was that if you got reminostat, you doubled the time until another treatment was needed. So you significantly extended the time between serious treatments. So that's a cool concept. That's very different than other approaches to lymphoma. And it really kind of backs up what we see in clinical practice, that keeping constant steady pressure on cutaneous lymphoma may actually be better for patients for keeping disease at bay, rather than this approach of hard rest. So in sum, early cutaneous lymphoma can be really hard to diagnose. And so hopefully that, at least partially explains why you or your loved one may have had to have a lot of biopsies, or there was a long delay in their diagnosis. The treatment paradigm is shifting for cutaneous lymphoma. I really think immune therapies, activating the immune system, especially the tumor microenvironment, and hopefully precision medicine, being able to target people's exact mutational profile, are the future. And with that, I will take some questions.
Thank you so much, Dr. Shinohara, for that excellent presentation. I know we have a question in the chat right now, and do feel free to send in any additional questions you may have, because we'll have the rest of the program for the Q&A session. So starting off, the question in the chat here, What has research shown linking autoimmune disease and CTCL? I have both ankylosing spondylitis and CTCL.
Mhm. No, it's a good question. So there isn't very strong connection between autoimmune disease and CTCL, um, with the exception of there is strong connection between autoimmune disease, um, particularly ones that cause sort of chronic inflammation, and cancer in general, particularly lymphoma. So an example is rheumatoid arthritis. Patients with rheumatoid arthritis are at higher lifetime risk of lymphoma. And so, there is this connection in that way. And it's thought that those autoimmune diseases are kind of, your immune system is sort of constantly inappropriately on, and that being a little bit too active all the time gives it more opportunities to collect mutations that then can lead to cancer. So beyond that type of connection, I don't think there's a specific one between autoimmune disease and cutaneous lymphoma. But there is in general, higher lymphoma risk with autoimmune diseases. I would say that can be a challenging combination though later, because some of the treatments for autoimmune disease, you can go the other way too, about, well, how does my lymphoma impact my autoimmune disease? Some of the treatments for autoimmune disease can actually promote cancer. And so we have to be really careful with particularly some of the immune suppressive medications, like TNF inhibitors, some of those new injection antibody drugs, because they can actually promote lymphoma. So for certain patients, that could be risky. And so it's always a discussion that, we would have as the, lymphoma treatment team with the autoimmune rheumatology team.
Thank you. Next question here is lacutamab for SS 4B, or is it for 4A as well? Are there more trials in the future planned out already?
Yeah, I don't know whether there's more trials planned out for the future. I'm guessing there are, or, I don't know of any that are currently ongoing, but I think it's likely there will be because the results so far are promising. So it will be, I'm thinking, likely going to be approved for patients with any degree of blood involvement is likely. So 4A and 4B would both be appropriate.
Thank you. Now, we do have just two questions that were sent in by a patient ahead of time, so I'm going to jump to those real
Okay.
quick.
Yeah.
Can we predict which patients will progress or when they will progress to later stages?
Yeah, I wish we could now. I don't think we're there yet, but I think that we're collecting more clues about how we might be able to do that. I think, there are some clinical features. Right now we rely a lot on, well, what do people look like when they come in? What are the characteristics of it? How advanced is it? How long's it been there? How symptomatic? Do they have tumors? We look at some, blood tests and things like that. Those are very blunt. I think where we're moving towards is looking towards that next generation sequencing, that precision medicine sort of arena, because there's some data that, for example, the next generation sequencing, clonality testing, the volume of clones that you can see with that testing is actually right now one of the stronger predictors of whether patients are going to progress later. So that's something that we need to look at more, obviously, but that could be because what we really want to know is be able to tell somebody with early disease, you can relax, or hey, we need to, stay a little more vigilant. So you can make plans and have a life, but we're not quite there yet. But I think we're getting better. But yeah.
Thank you. We did have a few more questions pop into the Q&A box here. So first off, this patient writes, I had a mediastinal large cell B type B lymphoma 22 years ago, mediastinal mass treated with R-CHOP and radiation, then breast cancer 5 years later, and last year T-cell lymphoma, which presented inside my ear. A biopsy was done, T-cell. I was treated with 12 doses of light radiation and declared in remission, which is great. But how would you suggest I monitor whether or not it is coming back?
That's hard. And that sounds like really terrible luck. I'm so sorry. 3 is not fair. I mean, one's enough. But I think, what we do for most patients with cutaneous lymphoma, like it really has to be a physical exam is our, because if somebody has a primary skin one, the most likely scenario with if they have recurrence is that it's going to come back in the skin. So really monitoring the skin is the biggest thing. If it's an area that's hard to get at, sometimes we might have to do imaging, but I would think starting with a physical exam, maybe ENT, if it's inside the ear, and then maybe imaging.
Thank you. And next question here is, first of all, they're saying awesome presentation.
Thank you.
But second, mycosis fungoides 1B treated for 2 years with NB, UVB, and acitretin. Great response overall. However, I continue to struggle with my scalp. Docs don't think it's mycosis fungoides, but after this, I'm not sure. Any thoughts on next step to get a diagnosis, like next generation sequencing or biopsy?
I mean, if you're curious whether scalp is involvement, I mean, first off, it's very common that some areas are hard to reach with narrowband. Assuming that you have hair, you have protection against the light therapy. So the narrowband often doesn't work so well in areas like that. It also can't access as well, like armpits and groin folds, things we call them sanctuary sites. So, if people do have involvement in their scalp, they for sure can, be sort of protected against the phototherapy. So if you're curious, you can always ask your providers whether they think a biopsy is appropriate. I'll say a lot of the times, we can assume one way or another. It may not change what we do though. So a lot of the treatments that we're going to do for that are going to be kind of similar, whether it's the lymphoma or not. So oftentimes it's really trying to focus on topical treatments for the scalp, which are just, a lot of them are hard to use because we have a hair. A lot of the treatments don't get on there very well. So it's a very tough area to treat. But yeah, if you're curious, talk to your provider about whether a biopsy would be appropriate.
Thank you. And the patient that wrote in the previous question, they just want to reiterate if asking you if it's inappropriate to have another PET scan now.
This was the patient with the 3 things.
Yes.
I would talk to your provider. It depends on the interval between the scans and things like that. I think there's a lot of variables that they'll be able to better counsel you on.
Thank you. Next question here. I had Graves' disease in 2004 after I was given radioactive iodine to my thyroid. My CTCL symptoms started. I was eventually diagnosed in 2011 after many tests and misdiagnosis. Have you seen other patients get CTCL after thyroid ablation?
No, there isn't a strong connection between those, as far as I know. And in fact, some of the new treatments are going the other way, potentially using radioactive iodide as a treatment. So, so far, no. But, anything is possible.
Thank you. Next up, would there be any complications treating CTCL post-liver transplant 19 years ago?
Yes, I think there absolutely could be, because all of those concepts about activating the immune system, we have to now be really careful about, because what we don't want to do now is promote rejection. Because if we activate the immune system too much, we could potentially cause, either organ rejection, or you can get graft versus host disease even in solid organ transplant. So yes, that's potentially. The other thing is that some of the medications that are used to maintain your organ, the immune suppressive medications, could potentially promote lymphoma. So this is another scenario like with autoimmune disease, where we work really closely with your transplant team. And hopefully people have sort of early disease that's external and skin only, that we can manage with topical external treatments. That's the best case scenario.
Thank you. Next question here is, phototherapy works well for my mycosis fungoides. I usually do 3-month sessions, 2 to 3 days a week, once a year. Is it safe to do sessions twice a year? Could that cause mutations? You mentioned over treating.
Yeah. So it's interesting with phototherapy, which is basically, concentrated sunlight, right? There's some theoretical concern that that could induce mutations. We know that sunlight, I'm a dermatologist, we know that that causes UV mutations that can lead to skin cancer. And so that has been a question with cutaneous lymphoma. Are we actually promoting potential people having worse disease with phototherapy? However, what we know is that people in general who are treated with phototherapy actually have better outcomes than those who are not. So it may be inducing mutations, but though it doesn't seem like those mutations are actually promoting lymphoma progression. So, so far what we know is that UV, yes, it may increase your risk of skin cancer. It's probably not increasing it very much, especially if it's narrowband, because the number of treatments until the skin cancer risk goes up, like people haven't actually been able to calculate that because it's so high. So it seems like the risk of second cancer development is really low, and it doesn't seem like it's promoting lymphoma treatment. So it's actually an example of something that people might use sort of more for maintenance, to be honest.
Thank you. Just going to get to two more questions
Okay.
here before we wrap up today. When apheresis is used as a first-line SS treatment, when do you say it has failed?
Oh, that's tough, because apheresis or photopheresis is a really slow treatment already. Um, so a lot of it depends on the patient and how they're feeling, how they're tolerating it, how far do they have to travel to get there. I mean, in general, I give photopheresis at least 6 months before saying, I don't know if this is going to work. Um, but I actually would expect continued improvement after 6 months. So if somebody even has a little bit of improvement, we might keep going for like a year before we totally give up. So you really want to give it an extended period. But if somebody's symptoms are really severe and we're not managing those with other things, then some people may not be able to tolerate that weight. And then I would say the treatment failed.
Thank you. Our last question here is I have Sézary 4A. Is the condition of my skin directly related to the amount of cancer in my blood? My skin is clearing up on my current treatment, so I'm cautiously optimistic. The Sézary cells in my blood may be decreasing.
Yeah. They may or they may not. We consider them separate compartments for treatment purposes, and not all drugs clear the different compartments equally well. However, it turns out that the blood in general, for most treatments, is a little bit easier to treat and clear than the skin as in Sézary. So the likelihood is if the skin is looking better, the blood is probably better. They don't always have to connect and correlate with each other, but probably it is. So yeah. The other thing too is like there's some risk with very high levels of Sézary cells. But for many, the range, up to like 5,000, it doesn't necessarily correlate with symptoms. So your providers may or may not be targeting what's going on in the blood. They may be happy, and you might be happy with, your skin being clear, even if there's some circulating in your blood. I often am with patients, like, hey, there's a little bit left in the blood, but your skin is clear, you feel great. I think this is a success. So the blood is just a number.
Yeah. Well, thank you so much, Dr. Shinohara, for your
Welcome.
presentation today and
For
for
the good
answering all of
question.
our questions. Yeah, they're really all really great. And just for everyone attending, please remember if you have any additional questions today, you can always reach out to our helpline at 800-500-9976. And that can be found at lymphoma.org if you didn't get a chance to write it down. You can also email at helpline@lymphoma.org. But with that, thank you again for joining us. And Dr. Shinohara, have a great rest of your day.
Thank you so much, Hope.
You're welcome. Take care,
Bye.
everyone.